Shobha Madam, Sudha Madam, everyone, I welcome you all. First of all, I would like to congratulate Dr. Jigna, Dr. Samyukta and whole Oasis team for completing the successful 1 year in Karimnagar. I would like to call Lilavati Madam, our Oasis Fertility CEO Sudhakar Jadhav sir, Dr. Lilavati, Dr. Padmalata, Dr. Shobha Rani Madam and Dr. Sudha Madam on the stage for the lighting the lamp. Dr. Jigna and Dr. Samita, please join us. Nilima, come on the desk.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धि विनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
The holy evening is started with the light lamping. It will be followed by the introduction of the Oasis Fertility branch and its development by its CEO Sudhakar Jadhav Garu.
Thank you so much, ma'am. I won't be taking much of your time. I think, first of all, very good evening to each one of you. I think today's session is going to be only single session. I would like to share my regrets. Dr. Durga is actually not feeling well. So she was supposed to come to this evening CME today, but unfortunately she could not make it. She has actually sent a regret message to all of us here. Yeah. Well, I think in quick next 5-7 minutes, I'm going to speak about Oasis Fertility, the journey of Oasis Fertility. As we speak, we just got into our teens. We are a very young company still. We have completed 13 years, got into 14th year of operations. Headquartered in Hyderabad. This was started way back in 2009 by our co-founders, both Dr. Durga Ji Rao and Mr. Kiran Gadela. We are a ICMR registered ISO 2000 certified organization. and we have been consistently ranked as #1 fertility center in fertility chain of clinics in South as well as in the country today. And we have been the most trusted experts as far as fertility treatment is concerned. These are the snapshot of both Dr. Durga and Mr. Kiran, who are our co-founders. And Dr. Krishna is, part of our core clinical team. Both Dr. Durga and Dr. Krishna manage the entire clinical operations of Oasis Fertility. As I told, unfortunate that she is not here with us today. Well, I think it has been a excellent journey for us in last 13 years. In fact, we have seen our growth trajectory in last 5 years. Last 5 years back, same time we were just about 4 or 5 centers. And today, as we speak, we have 30 centers and growing strong. And we would be kind of, having about 50 centers in next 2 years time. So that's the kind of growth which we are looking at across the country. For us, I think achievements and awards has been way of life. This is a very recent one where Economic Times has given us the award of the best healthcare brands for the year 2022. Series of awards. I think this is, as I told you, just a way of life for us, right? But I think what is extremely important for us is, what is extremely important for us is, for us, I think the core is our patient. We are fundamentally a patient-centric organization. For us, I think the most important person on the floor is the patient, right? So today, whatever success we found or success we have achieved in these many years is just because of our patients. In fact, our word of mouth actually increased by almost 70 to 80% in last few years. That's fundamentally because our the patient service excellence and the way we treat our patients fundamentally, right? We at Oasis, we don't compromise on certain values which are very, very close to our heart. Our fundamental ethos is that the entire team at Oasis, right from Dr. Durga ma'am to all the clinicians at every center, they strive very hard to give the biological child to the patients. That's the reason why fundamentally I think our donor cycles are far more lesser compared to the IVF space. We are just at about 12 to 13% at a company level, right? And I think we're not in a rat race to become a #1 or a #2 player. What we try is to kind of, be the most respected player in this IVF space, right? And that is where I think that's our differentiation fundamentally. Well, we have this core 5 values. We call it as compassion, competence, customized in the sense that we have all the treatments which are customized to the patients. We don't give the same treatment to all the patients. A lot of time spent by doctors in understanding the patient's requirement, needs, and then accordingly decision is given to the patient. Confidentiality, of course, the key. And when I say careful, we actually have one system called electronic witnessing system, which very few IVF centers use in the country today. So what happens with this electronic witnessing system is that we ensure that the gametes are not mixed, because world over, even today, there are about 16% issues or 16% mistakes still happen in the embryology lab. So fundamentally, to overcome those mistakes, we have this electronic witnessing system. I think by and large, apart from our core 5 values, we feel that our credibility is more important than commerce. We have been leading the IVF space so far. Looking back, we have done close to about 35,000 IVF cycles and close to 20,000 IUI cycles, and treated more than 65,000. We have a strong employee team of almost about 800 plus. So this is the kind of team which we have built up over a period of time. We have been adhering to the highest quality standards, NABH accredited organization. Most of our centers are QI accredited, and we are member of ASRM and FOXY. Right? When it comes to lab, I think there is no compromise. You will kind of agree with me that the core of any IVF clinic is lab, and we ensure that there is a class 10,000 environment there. all our consumables ME are tested for toxicity before they are used, and all our clinics are now equipped with electronic witnessing system, which I just spoke about. And we don't have a single clinic without a AHU. AHU is a must. Right? Today in the country, out of 4,000 clinics which are being operated, if you count the number of clinics which have AHUs, probably it is less than 300 or 400. And we are, of course, in that count. Right? Well, I think we give a wide range of services. I'm sure everybody give this Me Too products of IUI, IVF, etc. But I think what is important for us, particularly when we speak about Karimnagar, is what we have started is PGT, which we have been giving this service in Karimnagar, which is a major differentiation for us. We have started using a lot of embryo glue. We have started using a lot of microfluidics to the patient, thereby enhancing the success rate of the patient. This is our success rate, which is well above the global standard when it comes to overall at Oasis level. But speaking specifically about last 1 year journey in Karimnagar, I think we have done more than 500 cycles in Karimnagar, which is a phenomenal number. And our success rate on the first cycle has been about 67%, and overall success rate percentage of about 70%. I think this is entirely credit goes to Dr. Jigna madam and her entire team at Karimnagar. As I told you, we have been using microfluidics and embryo glue to the max in Karimnagar. One particular point which I would like to share to all our doctors here, that we are a daycare clinic. We don't do OBG, we don't do gynae work. We just focus on fertility. That is our forte. We ensure that whichever patient comes to us, the patient is after the patient conceives, we send the patient back to the gynecologist. So I think rest assured, we don't kind of treat the patient beyond 3 months. Well, this is one of the solutions which we have. It is called as Artis. Today, what happens is right from the first phone call till the live birth of the child, the entire patient journey is tracked in Artis, and this all happens in a system called Artis. It's a smart suit fundamentally, and we today, looking back, we have got data of about 13 years of about close to 65,000 couples, 65,000 patients, which actually gives us opportunity to get into AI in near future. You'll all agree with me that today the issue of fertility is just not contributed by females, but 50% is contributed by males. That's the reason why we started a dedicated clinic called AndroLife, which treats male infertility. You'll agree with me that male is always at denial and he's little shy to speak to a female counterpart. That's the reason why every clinic of ours has AndroLife, which we operate, where an andrologist, that is a urologist, would actually, treat the patients. And let me tell you on record here that in India today, maximum number of micro-TCs is being done by Oasis Fertility across the country today. This has been our latest innovative. This is a very urban product. It's called FertiCheck. Now, what happens in FertiCheck is we actually do semen analysis for the patient at home. So our phlebotomist actually goes to the patient home, and in the privacy of the home, this is being done. This service right now is available only in Hyderabad, Bangalore, Pune, and Chennai for us currently. This is one more new initiative of ours. We call it as IVFparents.com. It is fundamentally like a Google for all IVF data or IVF content. Fundamentally, patients can go onto this particular website. They can check all about IVF infertility treatments, and a lot of answers can be sought here by the patient. This is one more unique product of ours, which we call it as IVF at home, because today I think we give this service to patients. We understand that not everything can be done at home, but by and large, the injections are being carried to the patient's home, and we give this at the patient's home. So this is one of our differentiators, right? I think I've spoken about Amulia last year also. This is a corporate social responsibility of the organization. We believe that we should give back to the society, and I would strongly urge and request, in case if you have any needy patient, could be a maid, could be a rickshaw puller, could be an auto driver, who would come to your clinic. We are happy to provide an entire free cycle treatment to poor people. So please reach out to our BD team or Jigna madam in case if you have any such needy patients, we are happy to help them. So this is our, this particular project is called Amulya, where we do entirely free service to poor patients. Right. Last but not the least, I think for us, academic has been the core for Dr. Durga. It is one of our DNAs. We have been running FRM courses. We have intake of almost about 20 students every year. We also have 2 DNB seats, which is national board seats every year, 2 seats. And we also run both short-term as well as long-term courses. If anybody is interested, happy to kind of help you here. We have a counter outside. Please reach us out at the counter, and we'll be happy to help you. Right. So with this, thank you, Jigna ma'am. I would request. These were our 2 speakers. As I told, Dr. Durga ma'am is not here, so Dr. Jigna would take care of the further proceeding. Thank you so much.
So this was all about the Oasis, its development. They have done the 500 plus cases in Karimnagar. I congratulate Jigna. And now we will go towards the academic session. So Dr. Jigna will enlighten us regarding she's going to crack the USG puzzle and going to discuss some important cases with us. And she's also speaking about the adenomyosis. I would like to introduce her. Actually, we all know Jigna very well. No? Okay, fine. So you can just join and come, and we will start the session.
This is fine. This is next. Good evening, all of you. At the outset, I would like to thank all of you for taking your precious time out and coming here to, attend the CME. I know we are all a little upset that Dr. Durga couldn't make it, but I'll try my level best to keep you all involved in the session. I have many seniors sitting here. So I'll try to do my best. I'm sure most of you already know you have more experience, but certain things, let me just try to improvise it in my way. So we all know the mythology of Shiva's third eye. So Shiva opens his third eye when he's really angry at someone or this thing. So actually I was looking into this mythology. I never knew. I only thought that Shiva opens his eyes and does Tandava and things like that. So what I read about it is that Shiva's third eye opens up when he wants to, prove that there's something wrong going on, or it is an intuitive eye. It is an intuitive chakra. So for us as gynecologists, ultrasound is the intuitive chakra. So it is our third eye. So, but we can't like Shiva, we have to keep it open always. So today's talk, I'm going to basically cover what we need to do in a baseline scan. How do you monitor the cycle of a patient who we are treating for, follicular monitoring? Endometrial polyps, fibroids, adenomyosis. So we'll be discussing certain radiological terminologies which I feel should be uniform. All of us should talk the same language because this is now the consensus being followed. Uterine anomalies, hydrosalpinx, and a few common ovarian masses. She wanted to take up iota in detail, but that's going to be very elaborate. So let me see how much ever I can cover. So first of all, this is a baseline scan. I'm sure most of us do this. But what I want you to understand is what a baseline scan should include. So we are looking at the sagittal. This is a 2D grayscale image, real-time image that we are seeing. So we are going to see the sagittal section of the uterus. Look at the transverse section. Then we go to the ovaries. We sweep through both the ovaries. What we are doing is, which is called as eyeballing the ovaries. So coming to who, what and when. So who is the ideal candidate who needs to undergo an ultrasound? This we all know. We do it for almost all our infertility patients. And these patients, what is the ideal time? The ideal time to do a baseline scan, as we all know, is day 2, day 3, because that's when we know that all the parameters will be at the baseline level. We know that any kind of treatment that we want to start, this is going to be a guidance for us. So if at all during your 2D scan, which I will be highlighting in further slides, if you identify that there could be some kind of a Mullerian anomaly, you are going to watch them again in the luteal phase. So in 2D grayscale, what is the thing that you need to remember when you're doing? The structures which are perpendicular and closer to the probe are well seen. And structures which flow in Doppler, structures which are parallel are well seen. Any structure which is closer to the probe, which is perpendicular to the probe, will be clearly seen. Whereas any structure which is away, in fact, I'm sure most of you would have encountered that if the uterus is mid-position, you are unable to see it clearly. That is because the structure which is away from the probe will not be seen clearly. And whenever you're putting any kind of Doppler settings, any kind of Doppler in gynecology, always reduce your pulse repetitive frequency. There is a knob to adjust the PRF. Always reduce it to 0.6. The reason behind it is because the vessel's gynecological structures, the vessel have low intensity flows. So when the intensity is low, and if you're observing the structure at higher PRF, you're going to miss certain important findings. So you may miss a malignancy if your PRF is very high. So always remember, gynecological structures, your pulse repetitive frequency should be below 0.6. The lesser, the better. So what we are looking at the baseline scan is, I'm sure we are all doing scans, but little bit of organization and reporting will give us more information if we, just follow this checklist. So when looking at the uterus, always comment on the position of the uterus, whether it is anteverted, retroverted, or mid position. What is the size? Okay. Measure the size always in 2 orthogonal planes. I'll be showing it to you in subsequent images. 2 orthogonal planes, perpendicular planes. And any structure that you observe in gynecology, always take a volume, because a 3 measurement volume tells us that if there is any change in the structure in future, she comes back to you 6 months later and she has a big mass in her uterus, you know. The first thought that's going to come to your mind is, did you miss this? Did you miss this mass in the first scan? So always your volume guides you to tell you that whether you have missed or whether it is some new thing that has developed for the patient. Myometrium. When you look at the myometrium of the uterus, the myometrium echo texture is the baseline for you to compare any other structure. So when you look at the myometrium, always look for the anterior and the posterior wall thickness, whether it is uniform, whether there is any change in the echo texture. Now, next thing that you're going to get is the endometrium. So how is the endometrium? This has to be described as per data terminology, that is International Endometrium Tumor Analysis terminology, which has a very specific terms by which you have to describe the endometrium. Ovaries. So what we do with the ovaries is you eyeball the ovary. See the ovary in all directions. The purpose of doing it is not only to see and count the number of antral follicle counts, but also to look at the stroma. Now, why is the stroma is important? Because the initial early stages of PCO, you will not know. Maybe the number of count. Now, as per the new HRA guidelines, the count of the follicle that is required is 20 per ovary. But not all patients fit into that criteria. But we know patient is having irregular periods. She's coming to you. She's saying that I'm, not getting periods regularly. So how will you identify whether this patient is a potential PCO in future? By looking at the stroma. When you see patchy hyperechogenicity in the stroma, you know this patient is a likely PCO in future. Maybe she hasn't developed the typical features right now, but she is going to do so very soon. And adnexal lesions and the POD. So after you eyeball the ovary, take a transverse section, go to the section between the uterus and the ovaries and see if you identify any mass or any abnormal lesion, any ectopic or anything, hydrosalpinx in the adnexa. POD, you're looking for fluid or you're looking for any kind of peritoneal cysts, any other abnormalities. And then after you see your 2D image, you take a 3D image to sweep to see a 3D rendered image of the uterine cavity to see for any uterine anomalies. So like I told you, whenever you see the uterus, always take, 3 dimensions in 2 orthogonal planes. Pointer? No. पॉइंटर है क्या?
नहीं पॉइंटर है, इट्स वर्किंग. अगर नहीं वर्क करो
इधर ही दिखा. Okay, so this, when we look at the ovaries, also put a color Doppler in the stroma. So what does that tell you? Looking at the color flows of the stroma will tell you how much your patient is going to respond to your gonadotrophins or any kind of ovulation induction that you give. The more the flow, the faster she is going to respond. So you titrate your dose according to that. I'll be telling you the parameters of Doppler in the later slides, but always put a color Doppler. And this is a beautiful 3D image of a uterine cavity which shows the cornal edges as well as the uterine cavity. Okay, and little more additional thing that you need to notice in the 3D cavity image is look at the junctional zone. You all know the junctional zone or the endomyometrial junction is the innermost layer of the myometrium. So what is the thickness, how regular, how uniform it is looking is very important. Now, if you see fluid in endometrium, generally how will we proceed to taking the endometrial thickness? Any guesses? So as per the IETA terminology, take the endometrial thickness individually of each edges and add them up. Okay, so we take the endometrial thickness of each of the edges and add them up. So in this case, it is around 1.3 mm. Because there is fluid in the endometrium. So we're not going to measure it completely. So coming to the next topic, which I think most of us do it regularly, just a few tips on that. I'm sure all of us do it in the right way. A cycle monitoring. So more than 12 mm is a dominant follicle. This dominant follicle grows 2 to 3 mm per day. The ovulation can be expected anywhere between 18 and 24 mm. So very often we are restless. The moment we see the follicle is 18 mm, we want to trigger them, give them HCG. But the new concept is wait. Sometimes your endometrium may not be ready even when your follicle is 18 mm. So wait, don't be in a hurry. Let your follicle become 22, 24 mm, then you trigger. So that's that ideal time when the oocyte within is going to be mature. The cumulus-like shadow, if we are very keen observant, we may be able to see the cumulus-like shadow. Sometimes that's not very well seen in 2D, but if you just do a 3D sweep of the follicle, you may identify a cumulus-like shadow. The sonolucent perifollicular halo 24 hours prior to ovulation, somehow I haven't seen it very frequently. Any experiences, madam? Seen it, ma'am. Okay. Separation and folding in the lining 6 to 10 hours prior. So basically all these parameters are going to tell us when we need to do the IUI for the patient or when we need to trigger them. Coming to the follicular Doppler studies, this one thing is very common. We know that 3/4 of the follicle should have color flows, so that we know this follicle is a healthy follicle. Perifollicular vascularity surrounding 3/4 of the follicle, the resistant index 0.4 to 0.48. So these numbers are very difficult to remember. So what I always remember is Ri less than 0.5. That is my dictum. So any Ri less than 0.5, 0.5 is an easy number to remember. So anything less than 0.5 is fine. PSV, that's a peak systolic velocity more than 10 centimeters. So anything less than 10, we must be, maybe you don't have to counsel the patient, but at least you know that this kind of follicle may not be a very healthy follicle and may give rise to chromosomal abnormalities. So that does not mean that you have to cancel the cycle, because Doppler studies do correlate well, but they're not 100% sure. So PSV of more than 15 centimeter is that the LH search has already begun. It has already started, so maybe you don't need to wait till 36 hours, or maybe you can plan a double IUI. You can do IUI at 24 hours and maybe the next day too. So this is the beauty of a dominant follicle with a cumulus and color vascularity covering at least 3/4 of the follicle. So always what I would insist is always use the power Doppler. When you are using color Doppler settings, use power Doppler, or you can use HD flows. The HD flows will give you directional flow, and power Doppler will give you the color flows. So coming to the endometrium, now this description of an endometrium is as per the IETA. 7 to 8 mm during a cycle monitoring. 7 mm is what is a cutoff, and 8 to 10 mm is always the ideal. The morphology of the endometrium should be grade A or B. But there are 3 categories of morphology that are available: A, B, and C. A is our typical beautiful leaf-shaped triple line pattern with hyperechogenic line. B is wherein there is some blurring in the pattern. And C is a total homogeneous. You may not be able to differentiate the endometrium from the myometrium. So the vascularity should be zone 3 to 4, the Applebaum's classification. Now in this vascularity, what is important is, if you just see random dots and spots, that is not vascularity that you should consider. The vascularity should be regular. It should cover at least 5 mm square area of the endometrium. Then that is a flow, that is because we know Doppler will have a lot of artifacts. So if you're randomly seeing dots and spots in zone 3 and 4, you cannot label it as zone 3 and 4. You wait. Wait for the flows to pick up, stabilize, and see that at least 5 mm square of the area is being covered by your vascularity. So that will tell you that, yeah, this endometrium has good vascularity. Sorry. Okay, I need to go back. Yeah, spectral Doppler in the spiral vessels, again Ri less than 0.6 and pulsatility index of 1.1 to 2.3. So this is a beautiful follicular endometrium. I'm sure we all feel very happy, elated when we see this endometrium. We feel that, yeah, my patient is going to conceive. Okay, now coming to how you should describe, what I want to emphasize here is that you get into the habit of describing. So that is when you will not miss even small points when you are seeing a structure. So when you see an endometrium, you say whether it is uniform, non-uniform, whether it is hypoechoic, isoechoic, or hyperechoic, whether the midline linear hyperechogenic area is seen or no, whether the endomyometrial junction is regular or irregular, or sometimes like in Asherman's, it may be totally not defined. You may not be able to see it. And if there is any intracavitary lesion like a polyp or anything, and how is the vascularity of your endometrium. So these points should be there when you describe the endometrium. Now, like I have tried to describe this endometrium. So it is uniform, hypoechoic, triple layered endometrium measuring around 8 mm with hyperechoic midline with a regular endomyometrial junction and zone 2 vascularity. So these 5 to 6 points must when you are describing an endometrium. It's not like you just say ET 8 mm. No, this gives no information to anybody. So we need to start getting into the habit of describing the endometrium as per the AITA terminology. So again, this is just a picture of how a follicular phase endometrium looks and how a secretory phase. The more hyperechogenic the endometrium, the better the luteal phase for the patient. So post ovulation, we are looking at the corpus luteum, which shows a ring of fire appearance. I am sure all of us have seen it many times. The RI again, wherever there is good vascularity, RI less than 0.5. वो number याद कर लो, RI less than 0.5. And PSV 10 to 15 centimeters per second. The endometrial flow again RI less than 0.5. Uterine artery peak systolic velocity of 15 to 20 and a PI of less than 2.5. So this I take into consideration when I'm planning IUI for my patients. Whether the PI levels are between 2.5 and 3, that is the ideal time when you can trigger your patient. So uterine artery resistance, I have also had good correlations with the ovulation of the patient. So this is the reference that I have taken for this terminology. Coming to LUF, I'm sure this troubles most of us. Luteinized unruptured follicle, a persistent follicle. Now you're monitoring your patient, maybe for natural cycle or IUI, she hasn't ovulated. The consensus is wait and watch her. So sometimes I have seen follicles ovulate even later than 48 hours. So you can always call back your patient, repeatedly and see what's happening with her. So if the follicle is persistent and the wall is getting thicker and the consistency of the contents inside is changing, it's becoming more hyperechogenic and the endometrium consistency is also changing, echo texture is changing, then that is probably, this is a follicle which is going for luteinized unruptured follicle. Now, why does this happen? Why does LUF happen? LUF happens when there is inadequate surge or the follicle is not functionally mature. So HCG, preferably give 10,000 because the urinary HCGs that we get 5,000, we don't know how much of the product is actually potent enough. So giving 10,000 is always safer and don't trigger early. If you trigger a follicle early, before the endometrium is also satisfactorily ready, it's going to land up in an LUF. So follicle which is not functionally mature can become an LUF. Now, how to tackle this? Now, these tackling an LUF and things I have learned from Durga ma'am. So, she always suggested to me that if you have observed in your index cycle that this patient hasn't ovulated, the next cycle, give her GCSF 2 days prior to the time you want to give trigger, because GCSF helps to soften the wall of the follicle and the patient will ovulate. Like since when she has suggested to me, I also went through literature and I have seen most of my patients ovulate. Conceiving or not conceiving is a secondary thing, but the mind, the psychology they have is that I'm not able to ovulate. That fear is always there in the patient's mind. So there are a lot of nomograms that are available, and this is one of them which will help us to calculate the dose of, what kind of dose you need to give to your patient for stimulation. So higher dose is preferable when the age is more than 35, BMI is more than 28, the AFC count is less than 5, ovarian volume is less than 3 cc. We are talking in terms of poor responder. The stromal resistant index is high, more than 0.7, and the PSV is less than 5. So we know this particular patient needs more. And lower dose to be given to avoid any kind of OHSs to younger women who are less than 24, who are lean, less than 22 BMI, who have a higher intral, who are having a typical PCO morphology, the ovarian volume being more than 10 cc, the RI less than 0.5, RI number is fixed, 0.5 means low, everything low, PSV more than 10. So aim of any stimulation should be that we prevent OHSs. Particularly when we are giving natural and IUI cycles, it is very difficult to counsel the patient, tell them that you're having more follicles and we are not going to do the treatment this time. So the other option is always you can convert them into IVF. Suppose you land up in a situation where she's developing more than 4 or 5 follicles and you don't want to waste her cycle. She has taken gonadotropins and she's gone through the whole mental, pressure that she has to conceive this cycle somehow. So in such a scenario, if your patient understands, counsel her that another few days of injections and we'll convert this to IVF, your time to pregnancy is going to be earlier. So this is one thing you can do. You can prevent OHSs also, and at the same time, patient is also happy because she is going to conceive sooner. Now, quick bites about this. The number of small follicles, that is the antral count between 2 to 6 mm, is your functional pool. So always concentrate on that. Sometimes when you're eyeballing the ovary, you see some are large, some are small, some are cystic like. So always focus on this pool. The 2 to 6 mm is the pool. It will tell you how much of dose you need to give to the patient. AFC is the best predictor for ovarian response. A starting dose is always spot on. You start the correct dose, then you just wait and relax and enjoy the follicles growing. This is what I do. A steady rise in peak systolic velocity and a low RI is suggestive of impending rupture. So if your PSV is gradually rising, your resistance index is coming down, you know this follicle is going to rupture. This parameter is more important than your follicular size also. The fertilization of a follicle with low PSV can give rise to chromosomal abnormalities in fetus. Subendometrial blood flow on day 2. Now this is one more point which I feel all of you should go through. Whenever we are doing a baseline scan, always just put color flows on the endometrium. We know the endometrium is thin, but watch the subendometrial flow. So if you find that the resistance over there is more, this is the cycle where we know she may not conceive, because that's when the implantation potential of the endometrium is the least. So what is the reason for this kind of resistance? Maybe there's some subtle infection, some endometritis. That's the reason why the resistance is higher. So probably you can consider giving her antibiotics, wait for a cycle and then try in the subsequent cycle. I know as I'm talking, it's easy for me, but when you're sitting in front of the patient and you tell, no, we'll not do it this cycle, we'll do next cycle, she will sit on your head. So I think that judgment, if we can make them understand, it will make a difference in our practice too. So the next topic is endometrial polyps. These are very beautiful structures on scan. I'm sure all of you must have seen many. Oh, sorry. Yeah. So any growth which is arising from the endometrial lining. Okay, thank you. This may be associated with endometrial hyperplasia. Mostly benign, some may be associated with malignancy and they present with intermittent spotting and AUB. So I'm sure all of us know this. So these are polyps. So any structure, again I want to emphasize that any structure that you see, always take 2-dimensional measurements of the structure and calculate the volume and keep. Because now today you suggested her to go for a polypectomy. She said, no, I want to decide, I'll come back later. And later she comes back, you will not be able to see anything because the whole polyp has grown throughout the endometrium. So the volume that you have measured will help you guide what's happening with the structure inside. So measure the polyp in 2 orthogonal planes and report the location. So AITA says, now again AITA comes back. So AITA says that when you measure an endometrium with the polyp, you have to include the polyp in the measurement. Now look carefully. This is little difficult to identify. Because we are dealing with polyps, I am sure all of you identified it's a polyp. But otherwise, if you just see in the secretory phase, it is little difficult. So what will help you identify is this hyperechoic line. This hyperechoic line. So if you find this kind of a line in between the endometrium and the polyp junction, that tells you that there may be a polyp there. So again, you do a 3D, maybe you will get a clarity on that. So always the best time to look for polyp is follicular phase. Now again, these are certain points about the polyp. It is a circumscribed hyperechoic area in the endometrium. Often a fine hyperechoic line may be seen between the polyp and the surrounding endometrium, and some show some tiny cystic space because we said it may be associated with hyperplasia. The feeding vessel sign. This is a very important sign. A polyp will always have a feeder vessel. So look for it. If you have a suspicion, look for the feeder vessel. It is beautifully seen on a 3D coronal rendered image, and some may have a long pedicle too. You can actually trace the pedicle too. It is well visualized. If you already have some kind of fluid in the endometrium, it will be very well seen, or you can do a saline sonography which will help you identify and delineate the polyp very well. So this is the feeding vessel sign that you can see here. So this is the vessel. Okay, so always look for a feeder vessel. The feeder vessel is going to be running from the myometrium. It's not just a Doppler spot that you see in the follicle, in the polyp, sorry. It's going to be running from the myometrium through the myometrial junction. This is a 3D image. Like in this case, you can see that the polyp is arising from the left cornu. It has a subtle peduncle there, and then it's covering the mid cavity. The other one is a small, very small polyp which is there in the lateral wall of the left lateral wall of the uterus. So again, like I said, get into the habit of describing. This is again a hyperechoic lesion measuring 12 into 8 mm with smooth margins occupying the mid cavity and part of the left lateral cavity, which this appears sessile, suggestive of an endometrial polyp, probably benign. Now, why so much of description is because I know what I'm seeing is going to be benign. Now, you tell a patient, Amma mi garbasanchilo edo maamsamla kanipistundi, ala chepte, she will be like, "Are madam, is this cancer?" That is the first thought she is going to get. So, when you see such a scan picture, you don't say it's not cancer. You say most likely it's not. 90% I know this is not going to be a cancer because the characteristics of the polyp that we are seeing are like that. So in the same scenario, if you are going to see some spiky appearance, some cauliflower-like thing in the polyp, then you know this may be something malignant. So you need to sensitize her. So what is the importance of, polyp? Do we need to do polypectomy for everyone? Yeah, so what the studies say is polypectomy does improve the pregnancy rates, but you have to explain to the patient that this may be one of the reasons for your infertility. I have seen, in my practice, I have seen many patients conceive with polyp also. So that is like a double-edged sword. You tell them and then she conceives, she is going to ask you, "Madam, you said I will not conceive, I have conceived." So I think you explain the reason. Now, what does this look like? Anybody? Okay. The whole endometrium is polypoidal. Okay. So always observe the margins to look for any polyps. Now, multiple polyps. Suppose you see multiple polyps, each polyp will have a feeder vessel. So look for the feeder vessel. If the margins are regular, you're dealing with something benign. If they are irregular, spiky, cauliflower-like, they're likely to be malignant. Again, sorry, you can put in Doppler flows and see if the resistance index is less than 0.4, it could be malignant. The higher the flow, the higher the chances that it is malignant. Patients with CA breast. So I'm sure in our practice we see patients with CA breast. And they're on tamoxifen, look for polyps in their endometrium. You will find something. Any guess with this? Anybody? Nobody? Radha ma'am? Padma ma'am? Anybody ma'am? What this could be? These are RPOCs ma'am. So these are again sometimes confusing, hyperechoic. Our history is what important. We ask her the history of abortion. Fibroids. So fibroids, we know majority of women with 40 years, 40% of them have. It's a solid mass arising from the uterus. The margins are well demarcated. Occasionally, you may not be able to differentiate between a fibroid and the adenomyosis. So the typical feature of a fibroid is a linear, stripy, fan-shaped internal shadowing and edge shadowing. This is what differentiates a fibroid from an adenomyosis, the edge of the fibroid which you need to look for. The flow is always pericapsular, circumferential. Sometimes you may get intralesional flow also. So the intralesional flow is the one which confuses us between adenomyosis and fibroid. Variable appearances, you may have calcification, cavitation. Now we all go by the FIGO classification of telling the location of the fibroid. So mapping of fibroid is something which is very important. So how do you map the fibroid? The mapping of fibroid is something you should do it like a calculus problem. You trace the endometrium and you see how the fibroid is located. So these are the 4 pointers that you should look for when you are looking at the fibroid. Whether the fibroid is in the anterior wall, whether it's in the posterior wall, whether it is fundal, upper corpus, mid corpus, lower corpus, whether it's on the right side of the uterus or on the left side of the uterus. How will you know that? By taking a transverse section. Type of the fibroid. So type of the fibroid is based on the FIGO classification. So whether it is a submucosal fibroid, the type 2 to 5, whether it is transmural, whether it is subserosal, whether it is cervical. So why is this mapping important? So mapping of fibroid is important because fibroid, you know whether this fibroid is the cause of your symptom. Whether it also helps us to decide whether this particular fibroid needs surgery. All fibroids don't need surgery. But if they are interfering with the endometrium, you have to do something about it. It's going to affect your implantation. And it also helps the surgeon to decide the kind of approach he needs to take to operate. Now this is the fibroid. Anybody wants to describe as per the 4 pointers I suggested? Okay, I'll help you with this. So this is a posterior wall. Just focus on it. Posterior wall, upper to mid corpus, left-sided, transmural fibroid, which is not indenting the endometrium because we can see it is not pushing the endometrium or stretching the endometrium. And the color score of this fibroid is color score 4. So color score, I hope we all know. Color score 1 is no flow. Color score 2 is when there are few spots of color. Color score 3 is moderate vascularity, and color score 4 is where you see multiple branching of the vessels. So this particular patient that I had seen, so this the moment I saw this glass body display of flow on the fibroid, the first thing I thought is I'm dealing with some kind of sarcoma. I was so scared. I was like, no, this patient has to be operated immediately. We have to send for histopathology. But what I had missed with her is she had a recent history of abortion. So that is the reason why the vascularity was so high. So sometimes you can't just do scan and give reports. You need to talk to the patient and understand what really happened there. So this, what could this be? First impression. Anybody? Any guesses? So the first time I put probe into this patient, I was shocked. Arey, uterus mein, what is this hypoechoic? I put a color flow. It is so vascular. What is this? What is this? Then when I proceed with my scan, I saw this. So this, So this was a posterior wall, mid to lower corpus, right-sided, subserous fibroid, pedunculated subserous fibroid with such a vascular pedicle, okay, and a color score of 2. The fibroid as such was not vascular, but the pedicle and its attachment to the uterus was very vascular. So when should the fibroid be removed? to improve your IVF success rate or any kind of infertility treatment success rate. If and only if it is disturbing your endometrium, if it is stretching the endometrium, if the distance between your endometrium and the fibroid is less than 5 mm, then you need to think that probably this is going to interfere with my success rate of implantation. This particular fibroid, which you can see, the distance is 4.3, but this patient of mine conceived. Now be alarmed. When you're looking at fibroid, when is it that you need to be alarmed? If your fibroid is growing rapidly, if the vascular score is 3, 4, and if there are internal changes, you see some kind of necrosis, mottling and all, this could be malignancy. So be alert. Adenomyosis. Now coming to adenomyosis, this is something which I'm sure many of the patients are having of late. The moment you said Garbasanchilo koncham vaapundi, they are all worried. Vaapundi madam, vaapundi. Kari, this is very common these days, and we are seeing that it affects our implantation potential. So for adenomyosis, we need to follow the MUSA guidelines, that is morphologic uterus sonographic assessment, the MUSA group, which has given how to describe a adenomyosis lesion. So when you see adenomyosis, the first thing is identify the location, whether it is anterior wall, posterior wall, left lateral, right lateral, fundal. Differentiation, whether it is focal, mixed type or diffuse type, whether the adenomyosis is cystic, non-cystic, whether the EMJ or the endomyometrial junction is involved, what is the extent. If it involves less than 25%, this is mild adenomyosis. If it involves more than 25 to 50%, it is moderate. And if it involves more than 50%, it is severe degree of adenomyosis. And also describe, if you see an adenomyoma, describe the size of it. So these are the sonographic appearances that we see. We may have globular hyperplasia, globular enlargement of the uterus, asymmetric thickening. One of the walls may be thickened. You may see some cysts. You may see hyperechoic islands. You may see fan-shaped linear stripy shadows, which are also seen in fibroids. And you may see that there is some kind of echogenic subendometrial lines and buds, translesional vascularity is there, and the irregularities in the junctional zone. So this shows the subendometrial lines here, this one. Okay, so we need to really observe the endometrium very keen and carefully to identify this, and if there are any hyperechogenic islands. So these are images to show how the adenomyosis look, whether it is focal, diffuse, or whether it is an adenomyoma. I show you some scan images where we'll be able to correlate better. Cystic, non-cystic, and if there is any involvement of the junctional zone. Now this particular image, you can see that there is globular enlargement. The whole uterus is enlarged, and you can see there is heterogeneous mottled appearance of the entire myometrium. In this particular image, you can see that the posterior wall is more thickened, although the endometrium is well preserved. Okay, in this particular image, you see that the anterior wall is more involved. Now, just look at this video. You can see the linear fan-shaped stripes here. This is also referred to as the Venetian blind appearance or the rain in forest appearance. Particularly for the PGs, I think they will have to know these things. Oh, stuck. Image is stuck. It's moving here. It's not moving there. Okay. Yeah. Okay. So this video, if you carefully see, it's not coming. This video is not playing. Yeah. So this particular video, if you carefully see in the anterior myometrium, you can see a small hyperechogenic cyst, myometrial cyst, and a hyperechogenic area. I hope you people can appreciate. So this is actually a post-opio scan, but this particular patient had a hyperechogenic cyst. This is the initial stages of adenomyosis that she is setting into. Now, if you carefully look here, you can see that there are some endometrial buds here, and this is a myometrial cyst of the same patient. So these are endometrial buds that you see. So when you do a 3D, always look into the endomyometrial junction. Now this is total loss of the endomyometrial junction. This is referred to as the cirrhosis of the liver. Not liver, sorry, uterus, cirrhosis of the uterus. We are so used to cirrhosis of liver, it's cirrhosis of the uterus. Okay, so this is to show the intralesional flow in the adenomyosis. So you will have multiple vessels which are branching within the lesion. So the junctional zone, so now this is something new which we should start doing in our practice, start measuring the junctional zone. So the junctional zone is the innermost myometrium which is seen as a hypoechoic halo just beyond the endometrium. The difference between the maximum thickness and the minimum thickness, if it is more than 4 mm, then it is highly suggestive of adenomyosis. Anything more than 12 mm is an accepted criteria for adenomyosis. Anything more than 8 to 12 is something you need to be suspicious of. So what is the ideal junctional zone? Anything below 3 mm, 2.7 mm is that the pregnancy outcome is going to be smooth. Now why this? Because we know if she conceives with all this adenomyosis, regular junctional zone, is at risk of having abortions. So this is something for you to be alert. Now how do you differentiate between a fibroid and adenomyosis? These are certain pointers which may help you. So a fibroid is generally regular, lobulated with well-defined margins. You can see the edge shadow. The edge shadow is the most important thing which will help you differentiate. The flow is generally circumferential and the endometrium never runs through the fibroid. That is very important. In adenomyosis, you can see that the endometrium is running through and through the lesion. But in a fibroid, the endometrium will never be running. It's either stretched, pulled, but it's never running through a fibroid. So this is something you must remember when you are seeing them, when you are in confusion. Coming to uterine anomalies. Now uterine anomalies, we all know it's always a little bit of difficult dilemma when we see the uterus in the scan if there is any anomaly. So basically we go by the ASRM and ESHRE. My personal favorite is ESHRE because ESHRE doesn't give values. I'm little, very difficult to remember numbers for me. So ESHRE gives the patient's own myometrium can be considered as a guideline for you to decide whether this particular patient has a septum or no. So these are the images. I'm sure most of us go through this. But what I want to show is this particular image. This is as per the ASRM guideline of uterine septum. So if the depth is less than 1 centimeter and the angle is more than 90, in fact, ESHRE doesn't consider arcuate uterus at all, but ASRM does make a mention of arcuate. ESHRE feels that there is no implication of arcuate uterus on reproductive outcome. Septate, the depth more than 1.5 centimeters, you see the intercornual distance and drop a line down to the deepest point. If it is more than 1.5, then you are dealing with a subseptate uterus. And bicornuate, always look at the uterine contour. The contour is what is important. If the contour is fine, this is not biconvate. Reproductive outcome, I'm sure most of us know that it has been implicated as potential cause for infertility, recurrent miscarriages, preterm deliveries. So in a patient with infertility, now whether to operate septum or no is another dilemma. So in a patient with infertility, prior pregnancy loss, or if there is a poor obstetric outcome, it is reasonable you consider to do septal resection. And in a patient without infertility or a prior pregnancy loss, you can always counsel the patient and tell her that this may give you trouble in future. So if you consider resection, it is better. Now in scan, when you're doing a 2D grayscale, many of us may not be using 3D. 3D is, however, the best way to diagnose septate or any kind of uterine anomaly. But in case you are having a 2D grayscale image only, in such a scenario, if your endometrium is splitting, if you find that it is shorter in length in the midline, and if it's a broad transverse diameter of the uterus is there, then such a scenario you can suspect that this could be a uterine anomaly you're dealing with. So the best time to do a 3D for congenital anomalies is secretory phase, external, look at the external fundal contour, and always do a coronal 3D rendered image. So this is an image of a beautiful heart-shaped arcuate uterus. This is again an arcuate uterus because the distance between the coronal lines and the deepest point is less than 1.5. This is a video of the same patient that you saw previously. Sometimes it looks absolutely fine as normal, but when you put a 3D, you'll realize that there's something abnormal with this. So in this particular patient, the transverse section is what gives you a hint that there is some difference. The broad fundus splitting of the endometrium is the one which will tell you. This is a septate uterus wherein the distance is more. In her case, it's like 1.29. Again, we know that's where the ASRM lies in trouble. This looks like an obvious septum, but as per ASRM, you have to label it as arcuate. So that's why I feel personally that Eschere classification is more easier to make diagnosis. Now let's guess this one. Anybody? So 2D is tricky. 2D is really tricky for uterine anomalies. See, a relatively smaller uterus and the endometrium is going towards the periphery almost, towards the myometrium. This is a banana-shaped unicornuate uterus. So 2D is always tricky. Now, this was about uterine anomalies. Quickly about hydrosalpinx. I'm sure this is our favorite. If you just identify hydrosalpinx, I feel like it's an achievement. So a thick or thin-walled, elongated, folded, tubular, C-shaped or S-shaped fluid-filled structure with the adnexa. In the adnexa, if you see a waist sign, not my waist, a beautiful lady's waist, beads on string appearance, and a cogwheel. I'll just show you. So this is a beautiful hydrosalpinx. We see the S-shaped folds on itself, wave pattern. So that is a hydrosalpinx here. Okay, now the same thing reconstructed in 3D. Okay, it shows a beautiful hydrosalpinx there. This is when we use, so 3D, the beauty of 3D is use multiple modalities. So it helps you to see the structure in a better way. So this is when you use VCI, volume contrast imaging, you see a more clearer picture of the whole structure from where it is arising. So this is a nice hydrosalpinx with a waist sign. Now what's this? So this cartwheel appearance that you see, the spokes of wheel that we see, is nothing but a hydrosalpinx, probably a hematosalpinx. And here that you see, this very often we confuse it with a corpus luteum in the adnexa sometimes. So always differentiate your ovary, talk to the patient, symptoms, she's having pain, she's having fever, this is a pyosalpinx. A cogwheel appearance is a pyosalpinx. So PCO, I'm sure all of us are able to identify very easily. So what certain other important things is sono AVC. When we are looking at ovaries, sono AVC helps us to identify the number of follicles and the size and volume of the follicles in a better way. So this is a typical PCO. As per SRA guidelines, we all know follicular number more than 20 fits into the criteria. So since this has come, many of my patients, I can't label them as PCO because even though they have symptoms, so as per ultrasound, they are not PCO. So always measure the three-dimensional volume. Here you can see the volume of our ovaries is 28 cc. This is a video showing her ovaries. Okay, can somebody guess how many AFCs? Let's see. How many intels? Anybody? One ovary. Any numbers, ma'am? 40, yeah? Super, ma'am. You're so close. So when I put a sono AVC, she had 44 in each ovary. So this is how you get a report of the sono AVC, each follicle measurement, dimensions, volumes and all. So particularly after stimulation, it is of great help for you to decide when you want to trigger the patient. So like Padma madam rightly guessed, 44 ACs in each ovary. So this looks so beautiful. And you see, you feel like, I just want to admire this. Okay, so it's very, I'm sure all of you are waiting for dinner and the dance program and music program. So just a touch on aorta. Okay, all of us know all tumor and adnexal masses, ovarian and adnexal masses need to be described as per the aorta terminology. So I'm not going into the details. Basically what we need to do is use simple descriptors and simple rules to classify the mass. And if you are unable to do so, the third process of doing it is you take expert opinion. So this, any guesses? It's already there. So I'm just showing some few common ovarian masses that we see. So if you send to radiologist, they will give it to you as a complex, echogenic, mixed echogenic mass, kindly correlate clinically. So if you see this, don't worry, it's not a tumor, please. This is a simple hemorrhagic cyst. So the classical features is it will look very hyperechoic. You may not be able to differentiate between the ovarian stroma and the thing in an acute phase. But as it becomes old, you will be able to see that reticular cobweb pattern. There will be no flow inside. The video showed that there was no flow inside. The clot retracts. Sometimes you just push and see. You will see some jelly thing moving inside. That tells you that this is not a solid mass. The appearance will vary, and if it is less than 8 centimeters, it is physiological. You don't need to, catch them and operate them immediately. Now, these are certain other images to show hemorrhagic cyst. Now, what could this be? This is a very interesting case I had. Anybody can describe this? Spot diagnosis? Solid area, right, ma'am. So, what do you want to do with this patient?
Is like 2 to 3.
Yeah. It is more than 7 mm, ma'am. The distance of the papillary area that you are describing is more than 7 mm.
So it goes into simple descriptor in malignancy, favoring malignancy.
Okay, so I'll tell you the history behind this patient. So this patient is, she's a 28-year-old and she had endometriosis treated for infertility, not operated, and she spontaneously conceived. With this mass, she conceived. So now she's around 14 to 16 weeks pregnant with this mass. Now how do I proceed? Okay, no tensions, ma'am. We don't do anything with her. We just leave her. Let her pregnancy go on. You warn her. Okay. So basically, this is an endometrioma, ma'am, and the solid area that you're seeing is nothing but an irregularity in the wall. And what is important you should see is that in pregnancy, this area becomes rounded. The papilla becomes rounded. So it tells you that you don't have to touch her. Just leave her. If you see a mass with cauliflower-like spiky projections, high vascularity, that is when it's about it being malignant. But in this scenario, a rounded papilloma is nothing but a decidualization changes in pregnancy that happens in the endometrioma. The endometrioma we know is nothing but endometrial tissue. So the decidualization of the papilla is nothing but it becomes rounded. So we don't do anything to her. You just leave her. Let her finish her pregnancy. So if later, if she has any trouble with her endometrioma, we do something. Okay, now watch this video till the end. It's like those TikTok videos, watch till the end. Want me to play it again, ma'am? Yeah. So this is again a multilocular endometrioma we are dealing with. What you are seeing below is again irregular areas. Anything less than 3 mm from the cyst wall to the uppermost margin. All these I counted them individually. None of them is more than 3 mm. So those which are more than 3 mm are significant. The remaining are referred to as irregularities in the cyst wall. However, histopathological diagnosis is always confirmatory, but you know this is not something dangerous that you are dealing with. This one, spotter, PGs. Anybody? Ma'am, cotton wool like, bowel like appearance, acoustic shadowing, dermoid.
Dermoid.
It's a dermoid. Mixed echogenic, cotton wool like, bowel like appearance with acoustic shadowing. It's a dermoid. This video I just wanted to show for you to differentiate any kind of ovarian, para-ovarian cyst from a peritoneal cyst. So whenever you're dealing with this movement that you see here, this kind of a septa, that goes more in favor of a peritoneal cyst. Okay, so always when you're doing scan, you can make movements to understand what's happening inside. So thank you so much for your patient hearing. I hope I have justified the topic and I hope all of you enjoyed. Uh, and I would like to thank all of you as we complete 1 year at Oasis Karimnagar here. It's been a wonderful journey. I'm so grateful for all of your support and I wish all of you continue to support me. 5 years back when I came to Karimnagar, I was really puzzled. I didn't know whether I would be able to practice infertility because Karimnagar, I had never heard of it 5 years back until I landed up here. So today, after 5 years, I'm so glad that all of you have given me so much of love and you've had faith and belief in me. It's a big thing for me. I really thank all of you for being so grateful to me. Thank you.
I thank everyone for coming and be patient for the patiently listening the session. I think if anyone is having doubt, we can have that doubt during our dinner. So we from the Oasis, we want to felicitate our seniors. I would like to call Leelavati Madam. Leelavati Madam Peddapalli. Leela Madam, please. I would like to call Rama Madam for the felicitation. HOD Chalmara Medical College, please come, Madam. It's our pleasure to have you for the session, and we want to felicitate you, Madam. Please. I would like to call Vijay Bharti Madam from Godavari Kani. Please, ma'am. Please. Please come. She is doing the fertility practice in Godavari Kani. Such a small place, but she is giving her all her efforts for that small place. That is really very appreciating. I would like to call Shobha Rani Madam from Sirsilla for felicitation. I would like to call Adishini, madam. A very senior gynecologist. She is the main inspiration for the junior gynecologist for us. And our lovely Jansi madam, Women's Wing President, please come on the dais for the felicitation, madam. Such a dynamic Women's Wing President we are having in the Karimnagar. In this tenure, she is going to take the Women's Wing IMI to the some next level. I thank everyone for joining the session, and band came from the Hyderabad is waiting for you, and the delicacies, delicious dinner is also ready for us. So everyone, please join us for the celebration in the next hall with dinner. Thank you so much.